Next, I invite Dr. Sheera KR for the next topic, ROP screening, criteria, protocol, and methods. Dr. Sheera is working as vitreoretinal consultant at Aradhana Eye Institute, Trivandrum. Over to you, Dr. Sheera.
Very good morning to all. I'll be talking on screening criteria, protocol, and methods. Why this ROP screening is important in this scenario? Because it's a blinding disease, and identification of babies with ROP who all are at risk and likely to develop severe vision-threatening ROP is very important. Timely and early detection prevents undesirable sequelae and progression to an advanced stage. When we think about ROP screening, what all things we should know? I'm actually going into each of these steps, which infants need to be screened and when to perform the first screening, and what all are the screening methods, where to screen, how should be the management decision at each screening, and how stringent should be the documentation and communication. It's actually a very important step. And which infants need to be treated, and when should the treatment be done, and where to treat, whom to treat, and what all are the method of treatment, and how should be the follow-up, and how should be the long-term follow-up. These many things we should know properly before starting the screening options. Now first, which infants need to be screened? According to the Indian criteria, babies born less than 34 weeks of gestation and birth weight below 2000 grams, and babies with 34 to 36 weeks, even with risk factors, any of the risk factor if present, that baby needs to be screened. That is need of respiratory support, oxygen therapy more than 6 hours, sepsis, apnea, blood transfusion, exchange transfusion, or unstable clinical course. In the absence of reliable records, even a history of admission in the NICU is considered to be a surrogate risk factor, and that baby needs to be screened. When we compare to the screening criteria in the other countries, we can see in India it's a little higher limit, 34 and 2000 gram. But in India we have reported ROP which is vision threatening even in a little older babies. And next is where to screen and when to screen. All the screening should be done in a neonatal ICU, either in the step-down room, in the presence of a neonatologist, so that all the complications can be handled. But if the baby is already discharged, in such a babies can be screened either in the NICU when they are coming for the follow-up in the hospital, or can also be done in the ophthalmologist clinic. In the first screening of ROP should be performed within first 4 weeks of the life or in the admission period in the hospital. And if the baby is less than 28 weeks or the birth weight less than 1200 grams, such babies needs to be screened in the first 2 to 3 weeks to rule out the AP-ROP. And coming to the method, the gold standard ROP screening method now also it's indirect ophthalmoscopy by a trained ophthalmologist, but other screening options are wide-angle digital retinal camera, smartphone-based screening, and tele-screening approaches. How should be the dilatation? The dilatation of the pupil should be done with 2.5% phenylephrine and 0.5 to 1% tropicamide combination. It can be instilled 2 times, 30 minutes interval prior to the examination 1 hour before. Or the other way is 1 drop of 0.5% tropicamide can be instilled at least 3 to 4 times within 1 hour. And in such a situation, phenylephrine single drop can be instilled 15 minutes prior to the examination. The thing we should be careful about is the phenylephrine repeated instillation should be avoided because of the complications. And anesthesia 0.5% proparacaine can be instilled before the examination. Along with that, oral 25% sucrose or 25% dextrose can also be given. That's especially in a case of laser, during ROP laser. And other sterile single-use pacifiers can be used, and lead speculum to reduce the discomfort, and scleral depression to stabilize the globe, to rotate and indent the globe. This is the gold standard method of indirect ophthalmoscopy. The baby should be properly wrapped and the indirect screening should be done. And next option is the wide field retinal photography. The main advantages are it's easy to use by the nurse or a technician, and it eliminates the inter-observer variability. It's a good teaching tool, and also it helps to explain to the parents, and it overcomes the logistics of screening, and it's more cost effective than examination, and the tele-screening is possible. Fluorescein angiography is also possible with these wide-angle digital cameras, and it avoids the stress and the expertise of IO examination and indentation, especially in a beginner. These are the wide-angle digital camera options available. In that Trinetra Neo gives 120 degrees of fields, and RedCam gives 130 degrees of fundus, and Optos ultra wide field camera gives 200 degrees of the fundus imaging. These are the few examples of RedCam imaging photography, the pre-treatment and post-treatment images. And the other option is smartphone-based imaging. And the importance of telescreening in India is, India with 1.3 million people has less than 1,000 trained retinal surgeons, and less than 150 of them are currently practicing the management of ROP. So with the majority of the rural areas devoid of such experts, wide field imaging helps to bridge this gap. And this fundus fluorescent angiography can be used with this various fundus cameras like RedCam and the Trinetra and the Optos, and it's safe in children and can identify the pathology even it's not visible with the indirect ophthalmoscopy, and can improve the diagnostic accuracy and more accurately monitoring the efficacy of the anti-VEGF therapy in ROP. And OCT and OCT angiography, it's not routinely done, but can give an idea about the lesions, and can detect it early also. And the popcorn lesions can also be detected early. And the management decision at each screening is follow-up examinations are routinely required at 1 to 2 week of interval, depending upon the ROP stage and the decision by the treating ophthalmologist. And urgent treatment usually required within 48 hours in case of an AP ROP case, and also babies with treatable lesions, vision-threatening lesions. And ROP screening can be terminated once there is a complete vascularization of the retina without any ROP, or if the ROP has shown complete regression by around 40 to 44 weeks of the postmenstrual age. And how should be the documentation and the communication? In the present era, this slides has got a good importance, because whatever we find, each examination, the findings, and how should be the follow-up, timing, everything should be documented properly, and also it has to be communicated properly to the parents without skipping the follow-ups. And when we record the findings, each examination, we have to detail the zone, stage, and extent in clock hours of any ROP, and the presence of any pre-plus or plus disease. This is an example for the chart how we can record the ROP screening, baby's date of birth, and birth weight, and the present gestational age at each examination, and the risk factors has to be mentioned in the initial visit, and on the follow-up visit we can record the findings and the further follow-up visit details. And the zone, which zone is involved, and stages, whether the presence of pre-plus or plus disease, and clock hours of involvement, and whether AP, ROP present or not. And also we have to record the anterior segment findings also, whether the media is hazy, whether the corneal haze is there, and similarly any hyphema or anterior segment findings also has to be recorded properly. And each visit, follow-up visit date, time, and where the baby has to come for the follow-up, everything should be recorded and communicated. And we follow this ICROP classification, zones, stages, and plus disease, it's already covered. And who all will need the treatment? According to the ET ROP criteria, the type 1 ROP babies needs treatment, that is any stage of ROP in zone 1 with plus disease, and zone 1 stage 3 ROP without plus disease, and zone 2 stage 2 or 3 ROP with plus disease. And AP ROP definitely needs treatment immediately. And in type 2 ROP, zone 1 stage 1 or 2 ROP without plus, and in zone 2 stage 3 ROP without plus, these babies needs close follow-up. And coming to the treatment options, next presentation will be covering in detail regarding the treatment options, laser treatment, cryo and intravitreal anti-VEGF injections, and the surgical options. How should be the follow-up after treatment? Post-laser and post-injection, close follow-up to be done with weekly follow-up, and may need further laser treatment also. And infants treated with the sight-threatening ROP are at a high risk for developing refractive errors, strabismus, amblyopia, myopia, cataract, and also retinal detachment, and they should be followed up until at least 5 years of age. That should be the long-term follow-up plan. Thank you.
Thank you, Dr. Sheera, for that very excellent PowerPoint.